Welcome to the Ask the Expert webinars brought to you by the Wiley Knowledge Hub on atherosclerotic cardiovascular disease and lipidology, supported by Novartis. Our distinguished speaker for today's webinar is Professor Deepak Bhatt. Professor Bhatt is the Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Hospital and the Principal Investigator of the It trials. In today's presentation, Professor Bhatt will discuss the recently published It data. We request you to send your questions through the chat box and respond to the polls that will be presented to you during this webinar. At the end of the talk, we'll present your questions to our speaker.
Well, it's really my pleasure now to be able to provide an update on some recent data from It. So I will recap some of the original data as well, just for context and in case there are people in the audience that haven't heard the initial data presentations. Before I get started, these are my disclosures, and relevant to this specific talk is research funding from Amarin that's paid to Brigham and Women's Hospital. And my talk and the ensuing discussion may include off-label and/or investigational uses of drugs. The It trial, which I will be focusing on, was sponsored by Amarin Pharma. So first, a quick recap of the It design. The inclusion criteria consisted of statin-treated patients, 45 years of age or older, who had either established cardiovascular disease, which ended up being about 70% of the patients, and by that I mean coronary artery disease, cerebrovascular disease, peripheral artery disease, or diabetes plus at least one additional cardiovascular risk factor. That was about 30% of the population. So 70% secondary prevention, 30% high-risk primary prevention. Patients were meant to have triglycerides somewhere between around 150 and 500, though in fact we actually allowed, because of variations in triglycerides, between 135 milligrams per deciliter and 500 milligrams per deciliter, and in fact ended up getting about 10% of the population in the trial with triglycerides between 100 and 150. So that again has to do with variability in triglyceride levels. The LDL cholesterol was supposed to be at baseline between 40 and 100, and everyone was supposed to be on a statin and have received dietary counseling. And indeed, we know that they were adherent to their statin because their LDL was within the range I just mentioned, good control between 40 and 100. So in addition to the dietary counseling, in addition to ensuring everyone was on a statin and making sure they were in the inclusion criteria I mentioned, not having any exclusion criteria, assuming all that was the case, then they were randomized to either Icosapent Ethyl, a total dose of 4 grams a day, though specifically 2 grams twice a day with meals, versus a matching placebo. And the placebo was pharmaceutical grade mineral oil chosen to match the lack of color and odor of Icosapent Ethyl capsules. The patients were then followed up for a maximum of 6.2 years. It ended up being a median or average of 4.9 years. So you can think about a 5-year average follow-up. The primary endpoint was the first occurrence of any of the following: cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, coronary revascularization, unstable angina requiring hospitalization. So that's the trial in a nutshell. The background medical therapy at baseline was excellent. Everyone was on a statin per protocol, but beyond that, high rates of use of antiplatelet therapy, dual antiplatelet therapy, anticoagulation. That was largely in the 10% or so patients with atrial fibrillation at baseline. ACE inhibitor ARB use very high, beta block use very high. So this was a very well-treated population, high rates of use of evidence-based generic medical therapies. So everything I'm describing in terms of Icosapent Ethyl and its benefits is above and beyond patients already being on these great therapies. And here is the primary endpoint that I just mentioned: 5-point MACE or major adverse cardiovascular events, a hazard ratio of 0.75. So a 25% relative risk reduction, about a 5% absolute risk reduction, a number needed to treat of only 21, highly significant p-value. So very robust findings for the time to first event of that 5-point MACE. The key secondary endpoint was cardiovascular death, MI, or stroke, so-called heart events, and there the hazard ratio is 0.74, so about a 26% relative, about a 4% absolute risk reduction. Again, low number needed to treat, very significant p-value. So the overall trial for the primary endpoint and for heart events as well, significantly reduced. And for that matter, each component of the primary endpoint was significantly reduced, including reductions in cardiovascular death that were significant. The benefits in the primary endpoint were consistent across multiple pre-specified subgroups, as shown here. Same with the key secondary endpoint, consistent reduction across multiple pre-specified subgroups. I'll mention as well here those patients that had triglycerides at baseline that were below 150, so essentially between 100 and 150, quote unquote, normal triglycerides. There as well was a consistent benefit. You may not be able to see my cursor or the small sort of hazard ratio plot here, but a consistent finding demonstrating benefit even in those patients. This is our pre-specified hierarchical testing sequence. Basically, everything in green is statistically significantly reduced. As I mentioned, that included cardiovascular death, and it included every component of the primary endpoint, including a 31% relative risk reduction that was significant in fatal or non-fatal MI, 28% reduction in fatal or non-fatal stroke, and a 20% reduction in death from cardiovascular causes. Total mortality here trended, with a p-value of 0.09, trended towards being lower as well. And non-cardiovascular mortality had a hazard ratio of 1. So that reduction in cardiovascular death should have translated into reduction in total mortality had we only been able to continue the trial a bit longer. That was time to first event data. That is shown again here in green for the primary endpoint, the 25% relative risk reduction. But we also examined total events. That is not just the first event, but shown in orange here, recurrent events. That is someone that had an MI, but then had a stroke or a cardiovascular death or needed a bypass surgery. So that would be a recurrent event. And some patients had 3 or even 4 or more events. But in all these discrete categories, first events, second events, third events, and even fourth or more events, these were all significantly reduced with Icosapent Ethyl versus placebo. And overall, that was somewhere, depending on the methodology used, between a 30 to 32% reduction in total events. Actually, our pre-specified methodology was a 32% reduction in total atherothrombotic events. Large in relative terms, also very large in absolute terms, about 500 fewer ischemic events in the trial with use of Icosapent Ethyl. So that's a large absolute risk reduction. What about safety? In the overall trial, the drug was tolerated as well as the placebo, with no significant difference in treatment emergent adverse events, whether we use very sensitive definitions on the top row, where 80% of patients in each arm had an adverse event, or very sensitive definitions, or I should say specific definitions of treatment emergent adverse events. That's in the bottom row. There were about 2% of patients in each arm had adverse events leading to death. And in between are various other definitions with varying sensitivity and specificity. But the bottom line is the event rates are virtually identical in these 2 columns. The p-values aren't significant. So the drug was tolerated and is safe as placebo. And another thing I'll mention as well, just if anyone was concerned about our choice of placebo, the placebo was tolerated as well as drug. It would be kind of odd if either the drug was really having bad side effects or the placebo was having bad side effects, that by chance these numbers just happen to match up just right. It would be an amazing coincidence. So very well tolerated, a drug and placebo. As far as adverse events that were different, based on prior literature with the omega-3 fatty acids, we did look for bleeding, and we did find a significant increase when one looks at all bleeding treatment emergent adverse events. There's an absolute risk excess there of about 2% or so. The bleeding, fortunately, though, consisted largely of a minor bleeding excess when we looked at gastrointestinal bleeding, genitourinary bleeding, central nervous system bleeding, intracranial bleeding, adjudicated rates of hemorrhagic stroke, no significant differences. And these patterns of not having a significant difference in really bad forms of bleeding also persisted in patients on dual antiplatelet therapy, which was about 20% of the trial, as I mentioned, and in patients on anticoagulants, which was about 10% of the population. So if a patient is a good candidate for dual antiplatelet therapy or an anticoagulant or single antiplatelet therapy, then they're a good candidate from this perspective for icosapent ethyl. If the patient's very frail, already having multiple bleeding episodes, you're not wanting to put them on DAPT or anticoagulation because you're worried about bleeding, well, then they wouldn't be a good patient for icosapent ethyl either. The other adverse event that we noted was atrial fibrillation, specifically hospitalization for atrial fibrillation, which was adjudicated, was significantly increased from 2 to 3%. That occurred over the course of an average of 5 years. So in absolute terms, a relatively modest excess, but that was statistically significant with a p-value of 0.004. The rate of serious atrial fibrillation treatment emergent adverse events here in the middle was 0.5% in each arm. So the really bad AFib, again, no difference. But if one just looks at hospitalization, there was a significant difference. In terms of clinical sequelae, however, there was no excess of things like stroke. In fact, in the overall trial, stroke was significantly reduced by 28%. And even in the subgroup of patients with a history of atrial fibrillation at baseline or who developed it in the trial, rates of stroke were lower, not higher. Same with the other ischemic events. So in terms of atrial fibrillation, if a patient has atrial fibrillation that's well controlled in terms of their rate and are basically stable, then I think it's fine. If they're otherwise meeting the criteria, reduce it to start icosapent ethyl. If it's somebody with really unstable atrial fibrillation, getting hospitalized all the time, the rate's not well controlled, that wouldn't be a good patient to start icosapent ethyl. Okay, so that's the overall trial. The primary results that I showed were published in New England Journal of Medicine. That total events analysis was published in the Journal of the American College of Cardiology. Let me move on now to some other secondary publications. This one was also in the Journal of the American College of Cardiology, looking at the benefit of icosapent ethyl versus, or as a function of, baseline tertile of triglyceride. Bottom line, consistent benefit across all tertiles. I'll point out the triglyceride levels here did predict the rates of ischemic events. Look here in the placebo arm across tertiles, the rate of events really does go up quite substantially. So elevated triglycerides are a potent marker of risk, and now we see modifiable risk, modifiable by icosapent ethyl. But the benefit, especially in relative terms, was really quite similar across all three tertiles. The absolute risk reductions, numerically speaking, though, were larger in patients with higher degrees of baseline triglyceride elevation because they were higher risk patients. So higher risk patients tend to have larger absolute risk reductions from effective therapies, but the relative risk reductions in this case were essentially similar across all tertiles. So regardless of the triglyceride level, the patient's going to benefit, but they're going to have a larger absolute benefit the higher the triglyceride level. So that's the baseline triglyceride story, benefit across the board. Now let's look at some other biomarkers. I mentioned baseline triglycerides. We looked at it in multiple different cuts, and there was benefit that was consistent across the full range of patients we enrolled. We also looked at baseline CRP, and benefits were consistent regardless of baseline CRP. We also looked at baseline LDL cholesterol, including in patients in the lowest tertile. Again, the range of LDL at baseline was between 40 and 100, but even in patients in that lowest tertile, you can see a consistent benefit of icosapent ethyl versus placebo, hazard ratio of 0.67. So, and no signal that the benefit is attenuating as the baseline LDL is lower. If anything, graphically, it's looking like there's maybe even slightly more benefit, though that's not a statistically accurate statement. But certainly one can say there's consistent benefit, and indeed, even in the subgroups of LDL here by tertile, each subgroup is significant. So even if the LDL is well controlled, as it should be, even if you're using a PCSK9 inhibitor, which in high-risk patients you may choose to do, appropriately so, these are complementary forms of therapy. So yes, get the LDL low, but that doesn't mean that then icosapent ethyl isn't providing benefit. Indeed, here we show, even in that lowest tertile, which is much below the achieved LDL in real life in these types of patients. But even if in your practice you're doing that, doesn't mean that you wouldn't still benefit your patients by giving them icosapent ethyl, you would. And speaking of LDL and statins and that sort of thing, this is from a very recent publication in JACC by Dr. Singh, where we looked at the baseline statins looked at the primary endpoint, the secondary endpoint. We looked at the individual statin agents, and we looked at the statin category, lipophilic or lipophobic. Bottom line, for both the primary endpoint and key secondary endpoint, consistent benefit across different statin types, across the lipophilicity categories. So this provides further evidence that the benefit of icosapent ethyl is really incremental and added to beyond standard of care therapies that are hopefully commonly deployed. So further, I believe, reassurance that the benefits of icosapent ethyl really are independent of, additive to statin therapy. And even if you want to use really potent statins like atorvastatin or rosuvastatin here, you can see that the benefits are consistent in those subgroups as well. The final point I make about this slide, I think there's been some sort of silly debate about our choice of placebo of mineral oil, and it's interfering with statins, and that might have caused some of the large benefits seen in the trial. I've always thought that those arguments were really scientifically rather misplaced, but for people that were worried about that, if that were true, that mineral oil was interfering with statin absorption, you would expect the lipophilic, lipophobic analysis here to be impacted by that. But as you can see, the hazard ratios are essentially the same in both those subgroups. So it really further argues against some sort of weird statin malabsorption due to their choice of placebo that we used in the trial. Let me move on now to reduced EPA and talk about the actual mechanism of why the drug did provide such a large benefit. We looked at the achieved on-treatment levels of EPA in the trial and correlated that with reductions in various endpoints. And bottom line is the higher the EPA level, the greater the reductions in ischemic events. Though there seemed to be sort of a threshold in exactly where one can debate, but somewhere between 100 and 200 or so, it looked like there's a threshold, so that if you didn't really get to that level, you weren't achieving substantial benefit with the drug. So, other products that have been out there tested in trials, unless you're achieving these levels of EPA, it doesn't seem to really provide benefit. So I think the EPA level really matters. I think it also matters how you get there, and I'll come back to that point, because here with icosapent ethyl, it's a purified ethyl ester of EPA, and I think the drug and the formulation really does matter. So now let's talk about reduced interim. So obviously this trial was being monitored by an independent data safety monitoring board, so they sort of knew the results as the trial was going along. Those of us on the steering committee didn't know the results until the end of the trial, obviously, because we were blinded. But at the end of the trial, we got a chance to look at what the DSMB saw. And this is what they saw. We published this. Dr. Olshansky, the chair of our DSMB, published this in EHJCVP. And what is shown here is the first interim analysis, the second interim analysis, and the final analysis. What I showed you before is the final analysis. And you can see here, even at the time of the first interim analysis, there's a highly significant benefit in the primary and key secondary endpoint. So what this tells me, which I must say I didn't initially appreciate on presenting or publishing the data, is that the benefit accrued much earlier than many of us had fully recognized. So we often think about these sorts of secondary prevention or high-risk primary prevention type therapies like statins, benefit accrues over a long period of time, not so much an early benefit. But here, certainly the benefit does accrue over time, but it kicks in pretty soon too. And just to put some math around that, these curves are a continuous landmark analysis of the primary composite endpoint, showing that there is a consistently statistically significant benefit by 21 months. So by about 2 years, it's significant. But the dark blue line is the hazard ratio. So it's favorable really soon after randomization. It just takes a little while to become statistically significant. So the benefits kick in rather early here. A reason not to delay initiating therapy in appropriate patients. Sometimes doctors say, well, I'm going to try this, I'm going to try that. Sure, try those things. Get the patient's LDL better, get them to lower weight, but it doesn't mean you should put off initiating icosapent ethyl if they otherwise meet the criteria of the trial. The key secondary endpoint was also significantly reduced by around 2 years, 25 months to be precise. But once more, the benefits accrue early on but becomes statistically significant by about 2 years. Let me move on now to reduced adjudication. Dr. Gaba, one of our fellows here at the Brigham, just published this in JACC a couple of months ago. We, in the overall trial, in the New England Journal of Medicine paper, reported the independently adjudicated events. What is shown here now are reported events that are reported by the site investigator, also blinded, but basically if the doctor at the site says, yeah, this was a heart attack, it's a heart attack. Whereas adjudication, that goes to a blinded independent committee that says, well, not sure this one's a heart attack. Oh, this one looks like a heart attack. So, it's just an added level of examination of the data. But bottom line is our primary endpoint hazard ratio 0.74 with investigator reported events, rather similar to the 0.75 from adjudicated events. So the bottom line message doesn't change. Whether you use independently adjudicated events, site investigator reported events, the degree of benefit really looks the same and quite large. Large relative and absolute risk reductions here, as with the adjudicated primary endpoint. If anything, there's slightly more events here, so slightly higher absolute risk reduction when we use investigator reported events. This is the primary endpoint. Same thing here, investigator reported events for the key secondary endpoint of cardiovascular death, MI, stroke. Once again, very significant, 25% relative risk reduction. Let me move on now to reduced diabetes. This is a pre-specified analysis looking at patients with diabetes from both the secondary and the primary prevention cohorts of reduced. And shown on the left is a primary endpoint, key secondary endpoint, cardiovascular death, MI, stroke on the right-hand side. The blue is icosapent ethyl, red is placebo. The light shading is time to first event, the typical conservative way of looking at data. And the dark blue and red are total events. So not just the first event, but recurrent events. And as you can see, first of all, these patients had very high event rates. These are stable outpatients that got enrolled, but by virtue of having elevated triglycerides, sometimes it's mildly elevated, but still elevated despite being on statin, despite dietary counseling, and now also having diabetes, these are super high-risk patients. Look at how high the total event rates are here in the placebo arm, but even in the treated arm, still a fair amount of residual risk, even after icosapent ethyl. So a lot more we will need to do with this targeted patient population in terms of future therapies. But as far as icosapent ethyl goes here, you can see robust, consistent reductions no matter which endpoint or how you analyze the data. So as in the overall trial, significant benefits, but event rates really markedly increased and very large absolute risk reductions here. Let me move on now to reduced BMI. This is some more data from reduced looking now at the baseline body mass index, and here's the distribution in this pie chart. A lot of the patients were obese or overweight, as is true in this population in real life, but there were some patients that had a good body mass index, less than 25. But how did the drug fare? Well, across the board, again, same color scheme as in the diabetes slide, consistent benefits across all these different BMI categories. Importantly, even in those patients with a BMI at baseline less than 25, consistent benefits, both for time to first event and for total events. So again, if the patient's overweight or obese, yes, help them lose weight. But that doesn't mean you shouldn't use icosapent ethyl and just wait for that time that they're going to lose weight, which may never happen, as is most often the case. So these are all complementary approaches, not either or. So much like the case with LDL, yes, control the LDL, yes, control the BMI, but don't use elevated LDL or elevated BMI as excuses or justifications for not using icosapent ethyl in patients who would otherwise be qualified for it. So these are the BMI analyses from reduced. I'm actually going to present the waist circumference analyses at the American College of Cardiology in 2022. Now let me share with you reduced renal. This was published just a couple of months ago in Circulation by Dr. Majithia. He looked at the baseline eGFR, both pre-specified and also post-hoc analyses, different cut points of GFR for the primary endpoint. Once again, bottom line, consistent benefits across the full range of studied eGFR for the primary endpoint, Same story for the key secondary endpoint. So no signal of attenuation of benefit as the GFR gets lower. Some therapies, as you're aware, when the GFR is low, it's not so clear that the therapies work. Here, there's no evidence that there's less benefit as the GFR is becoming impaired within the range of patients we studied here. Let me move on now to reduce-it stroke. This was presented at the International Stroke Congress, actually won the Paul Dudley White Award there. Here we looked at the effect of icosapent ethyl in reduce-it on first and total ischemic strokes, finding significant benefits on that endpoint. And as I showed you a few slides back, I went through it quickly, there was no significant excess in hemorrhagic stroke. So a reduction in total stroke in the overall trial is reported in New England Journal of Medicine, but now really honing in on ischemic stroke, showing the significant reductions there. So I must say the stroke neurology community, at least at the ISC, was very excited about these data. Now a new therapy that's effective at reducing risk of ischemic stroke. Let me move on now to reduce-it prior PAD. I presented these data at the American Heart Association. And here we looked at first and total endpoints in patients with prior PAD, without prior PAD shown on the right-hand slide. And again, the same color scheme as before, a story of consistent benefits across this subgroup as well. So really, regardless of the atherosclerotic manifestation the patient was having, consistent benefits favoring icosapent ethyl versus placebo. So this isn't just a coronary artery disease drug. It's not just a diabetes drug. It's really a drug for patients that are at risk, either with evident atherosclerosis anywhere in the body or with diabetes plus additional risk factors. Let me now share with you reduce-it revas. This was published in Circulation, I think it was online in 2020 and print in 2021. But at any rate, here, Dr. Peterson, one of our interventional fellows at the Brigham, looked at the endpoint of coronary revascularization, finding a significant benefit of icosapent ethyl versus placebo, large relative and absolute risk reductions in this endpoint. And here, the time where the benefit kicks in is really quite early. Within a year of randomization, right around 11 months or so, a significant benefit. But once more, the dark blue line is the hazard ratio, the dotted blue lines are the 95% confidence intervals. There's directionally speaking benefit soon after randomization, but it becomes statistically significant by about a year. So for this endpoint, a very, very early benefit that kicks in. And the benefits of icosapent ethyl versus placebo were consistent on the endpoints of significantly reducing elective coronary revascularization, urgent revascularization, even emergent revascularization in this blinded, independently adjudicated trial was significantly reduced. And importantly, again, in a trial that was blinded, independently adjudicated, there were significant reductions in the need for percutaneous coronary intervention, also a significant reduction in need for coronary artery bypass graft surgery. So that tells me that there is really a profound effect on atherosclerosis, on ischemia, sufficient that in a blinded trial, the doctor and patient thought, don't need to have that bypass surgery. So to me, that's saying the drug is really affecting plaque in a pretty fundamental way. And, we don't have mechanistic data from this trial, but there's imaging data from IVUS and OCT and CT angiography of icosapent ethyl, essentially corroborating the beneficial effects on plaque, including in randomized imaging studies. So really a lot of mechanistic data that now backs up what we're seeing in a randomized clinical trial. And we haven't really seen these sorts of large relative risk reductions in revascularization or in ischemic events in general since the 4S trial, which, as you recall, was a trial of statin versus placebo. Here, everybody's getting a statin, and it's icosapent ethyl versus placebo. So really large benefits building upon the known benefits of statins and other evidence-based medical therapies that were in high use in this trial. Let me now share with you reduce-it PCI. This actually just got published in the past week in the Journal of the American Heart Association. Again, Dr. Peterson, our interventional fellow from the Brigham, was the one that first authored this. And here, looking at the primary endpoint in the subgroup of 3,400 patients who had a history of prior percutaneous coronary intervention. In that subgroup, we see a large and significant benefit favoring Icosapent Ethyl versus placebo, a relative risk reduction of 34%, an absolute risk reduction of 8.5%, a number needed to treat of only 12. This is the primary endpoint. Here is the key secondary endpoint, CV death, MI stroke. Same sort of message, large relative and large absolute risk reduction, a 5% or actually over 5% absolute risk reduction in hard events. So really, this is a subgroup that's easy to identify, where if they otherwise meet the reduced inclusion criteria, something to strongly consider using. And we looked at safety and bad bleeding and that sort of thing, and no significant excess in intracranial or fatal bleeding or anything like that, despite high use of dual antiplatelet therapy in this population. Let me now share with you Reduce-It Cabbage. This too was published in the past few months in Circulation by Dr. Verma, a well-known cardiac surgeon from the University of Toronto. And here we see in the 1,800 patients with a history of prior Cabbage, it's a pretty big subgroup that's larger than many trials of Cabbage. But in this subgroup, once more, a consistent benefit favoring Icosapent Ethyl versus placebo. Again, large relative, large absolute risk reductions for the primary endpoint. Here as well for the key secondary endpoint. Only need to treat 17 of these patients with a history of Cabbage to prevent one cardiovascular death or MI or stroke. So important hard events that are prevented, large numbers of events prevented. So again, these patients are easy to identify. If someone's had a prior bypass surgery, that's extremely easy to figure out from their medical record or history. And if they otherwise are a Reduce-It eligible type patient, then I would say strongly consider using the drug. Now let me share with you Reduce-It prior MI. This was previously presented as a late breaker at the European Society of Cardiology. It's in press right now in JACC. And basically what this study did was examine the patients with a history of prior myocardial infarction. And in that subgroup, you can see large, significant reductions in ischemic events, primary endpoint, key secondary endpoint, first events, total events, across the board, significant benefits. So once more, very easy to identify subgroup of patients, and one that's known to be at high risk, patients with prior myocardial infarction. So these are patients you really want to be quite aggressive with in terms of lifestyle modification and medical therapy. As well, in this analysis, we look at cardiovascular death, sudden cardiac death, cardiac arrest. These endpoints were significantly reduced in the overall trial. I didn't mention that before, but sudden cardiac death and cardiac arrest were pre-specified, independently adjudicated tertiary endpoints, and those were significantly reduced in the overall trial. But here we see in the prior MI subgroup, even greater degrees of benefit on those particular endpoints. And just here, examining those data graphically for sudden cardiac death and cardiac arrest, we see significant benefits of Icosapent Ethyl versus placebo. The results are consistently statistically significant for these endpoints by about 4 years. So revascularization, the benefits kick in by a year and are significant. But for some of the harder endpoints, like these ones, it takes a little while for the full drug effect to accrue. That's why I made the comment before about all-cause mortality. I think if we'd had enough funding to continue the trial longer, then we would have seen all-cause mortality reduced. But it might have taken 5 or 6 years for that to be fully manifest. These are some data before I wrap up about this topic on omega-3 fatty acids more broadly. So I've been talking about Icosapent Ethyl, which is a prescription version of a highly purified ethyl ester of EPA, but there are other omega-3 fatty acid trials that have been done with EPA plus DHA in red, some using prescription medicines, some using prescription medicines that have been taken off the market, some using supplements, dietary supplements. But the bottom line is here you can see if we pull all the trials of EPA, largely Reduce-It and Jealous, but some smaller trials as well, a consistent benefit across ischemic events favoring EPA in blue versus control. In some cases placebo, in some cases open label, meaning randomized and no actual placebo, as in the Jealous trial. Whereas with EPA and DHA, it's a much more mixed message through the years. Some signals of benefit potentially, but just not clear enough to be actionable or actually use those supplements or prescription EPA, DHA compounds. Even though some of them are approved for triglyceride reduction, they don't reduce ischemic events. So the EPA versus EPA, DHA, there are differences in what the clinical trials have shown. There's also differences in the biology. For the sake of time, I didn't want to go through too much basic science here, but there's really a ton of science and even more to come, just showing the different effects of EPA and DHA. Here are shown differing effects on cell membranes and work based on Dr. Preston Mason in his lab, but there are other effects as well. And I'm not saying DHA is bad. I think there may be uses of DHA with respect to human health that are beneficial. But for cardiovascular risk reduction, EPA is what's proven, and EPA plus DHA has not been proven. In fact, the DHA may even counter some of the cardiovascular benefits that EPA would otherwise have provided. So really, what I have said in this presentation shouldn't be generalized to the class of omega-3 fatty acids. It specifically applies to EPA and more specifically applies to prescription icosapent ethyl. So I'll conclude now by just stating, as we did in this EHJ perspective, that the profound reductions in first and total cardiovascular events with icosapent ethyl in the REDUCE-IT trial really should usher in a new era in dyslipidemia therapeutics. And the major challenge now, I think, is implementing these trial results in real-life practice. Well, thank you very much for your attention. I hope that this top-line review of REDUCE-IT, and in particular, some of the newer analyses, many of which were just recently published, some of which are still in the process of being prepared for submission for publication, has been useful to you and provides the full context of the data for icosapent ethyl. Thank you so much.
Thank you, Professor Bhatt. That was a very comprehensive presentation, lots of data out there, massive amount of work. I have questions from the audience, but I think you've answered most of those during the presentation. We'll still go over them. So I'd like to start out with a question that's really more general. And the question is that there's a hype in cardiovascular disease cases around the globe. Would you comment on the reasons in light of current research as to why that is the case? Maybe tie in the other question, can you comment on the burden of CVD?
Yeah, I think that's really a great question, very important. Globally, rates of cardiovascular disease are skyrocketing. Now, there is some degree of regionality to it. In high-income countries, at least over the past few years, the rates of cardiovascular disease did seem like they were going down, but then maybe plateaued. In low and middle income countries around the world, rates of cardiovascular disease are just skyrocketing, and there's no evidence of that slowing down anytime soon. And the reasons are complex. In sort of lower and middle income countries, it has to do with urbanization, movement to a more sedentary lifestyle from one that involved more manual labor. It also involves diets that have become sort of fast food and unhealthy diets. I personally think a plant-based diet is the most healthy one, and one that people should adopt if they're concerned about cardiovascular cancer risk, or even the environment for that matter. But that diet is globally not one that's widely adopted. So I think diet has a lot to do with it. Being more sedentary, weight is increasing around the world, probably as a consequence of being more sedentary, more transport by auto as opposed to walking, and dietary influences. So all those things are fueling an atherosclerosis. Maybe I shouldn't use the word, but I'll say pandemic, because it really is something that is affecting, hundreds of millions of people. And even in higher income countries such as the US, it's not really fair to say that rates of cardiovascular disease are going down. There's regionality to it as well. That is, not every demographic group has seen that. In the more rural parts of the United States, the rates of cardiovascular disease are actually increasing, and of cardiovascular mortality. We published on this in JAMA a couple of years ago. So It's the rural parts of the U.S. are really facing, I'd say, in some cases, horrible rates of cardiovascular complications. And for example, in middle-aged men, for a demographic to pick, in rural areas, rates of cardiovascular disease have gone up quite markedly. So there certainly are lots of challenges that we're facing globally. And the COVID-19 pandemic, it's awful in its own right, but I think it's helped fuel cardiovascular disease, at least in the city where I'm practicing, Boston. All of our teaching hospitals in the city are currently being overwhelmed by a large number of cardiovascular patients. And I don't mean complications from COVID. There's some of those, I think, but not so many. I'm just talking about people that maybe because of deferred care have sort of fallen apart, cardiovascularly speaking. That is, they've taken up smoking again, or they put on 20 pounds during the pandemic, or their diet or exercise patterns have suffered. So I think we're going to see the consequences of this pandemic, not just for the next several months, as we are currently experiencing, with large numbers of, cardiovascular disease patients coming in. And some of that was from deferred care, but some of it is just they're coming in with decompensated heart failure, they're coming in with acute coronary syndromes. But I think the sequelae of inadequate risk factor control for basically 2 years is going to be felt for many years. I also think it's I shouldn't say it's but it's sort of a natural experiment that shows that prevention really does matter. All those different things: lifestyle modification, medical therapy, showing up to the doctor, getting your annual physical. Those things really do add up and reduce cardiovascular risk, probably other risks too. So great question. But lots of things are fueling the cardiovascular epidemic or pandemic, or whatever you might choose to call it.
That was very insightful as to what you're actually seeing at the clinic. I'm sure other countries are also seeing this all over the world. The next question kind of leads in from the last few slides that you showed on the omega-3 fatty acids. The question is, what makes Icosapent Ethyl so unique, knowing that previous formulations did not really show the best clinical outcomes in the past? Could you comment on the formulation?
Yeah, that's a really important question. I mean, in clinical trials, the drug matters. You can't just always say, oh, everything is a class effect. So we're talking, yes, about omega-3 fatty acids broadly here. And I think if we were talking about diet, well, omega-3 fatty acids do seem to be a good thing when obtained from the diet. But those dietary studies are tough because foods that are high in omega-3 fatty acids tend to be high in other good things. So is it those other good things? Is the omega-3 fatty acids? Is a little of both? I mean, I think it's probably a bit of both. So if one wants to get omega-3 fatty acids naturally, I would say, good, go for it, especially for people that are healthy, trying to stay healthy. I don't think they should go on drugs if they don't need to. But if we're talking about healthy diet, so if you want to get omega-3 fatty acids naturally from the diet, well, there are some dietary sources. So for people that are vegetarian or vegan, chia seeds, flax seeds, walnuts are very good sources of omega-3 fatty acids. Green leafy vegetables, to an extent, some of them also can have reasonably a good omega-3 fatty acid content. So for vegetarians and vegans, those are reasonable ways. However, the enzymatic steps in the human body to convert what would actually be ALA from those different foods into EPA or icosapent acid are pretty inefficient. They're a little bit more efficient in premenopausal women, but even there are relatively inefficient. So if you want to get really high levels of EPA through vegetarian vegan diet, it's actually rather challenging. But those foods that I mentioned are still good because they will get you some omega-3 and they'll get you a bunch of other good things. So you should eat those things if you're not allergic. Fish would be, for people that eat fish, a relatively good source, fish and seafood, of EPA, icosapent acid, also DHA, docosahexaenoic acid. But even there, even if you're eating a ton of fish every day, you're not going to get to the levels of EPA that prescription icosapent ethyl would. So again, for a healthy person who likes to eat fish, that's a reasonable thing to do. But for someone that to reduce it like patient, just saying eat more fish wouldn't really accomplish what we were able to accomplish with the dose and formulation that we used of EPA, Icosapent Ethyl. So diet, great, but it can't match the levels that we achieved in the trial. As far as the actual drug then to use, well, dietary supplements are a consideration. Around the world, people can just walk into a grocery store or pharmacy and buy them without a prescription. Those are very poorly regulated, first of all. In the U.S., I'll speak about, the U.S. FDA kind of regulates dietary supplements. That is, they do ensure that they don't, contain poison and that sort of thing, but they aren't actually evaluating dietary supplements for the claims they're making, nor are they assessing them for their purity or batch-to-batch consistency. So my colleague, a basic scientist here at the Brigham and Harvard, Dr. Preston Mason, looked at the leading U.S. dietary supplement. You can buy it just in a store without any physician or prescription involvement. First of all, it varied a lot from batch to batch, and it had a lot of other stuff in it other than omega-3 fatty acids, lots of other fatty acids, all subject to oxidation, so that even if the EPA content should have provided some benefit from that dietary supplement, all that other stuff in there, the fatty acids getting oxidized, even the EPA potentially getting oxidized, could thereby undo what benefit would be expected. So, the formulation matters. I really don't recommend dietary supplements. And by that, I'm not just meaning omega-3, I mean even other ones. Patients, I must say, hate to hear that because they love their dietary supplements, even though those things aren't cheap. They don't mind paying for them. In fact, I think the psychology of it is the fact that they're paying for them, they attribute value to it. And therefore, when the doctor says, stop taking it, it doesn't provide any benefit. Even if I cite randomized clinical trials showing lack of benefit, they do it. So whether it's vitamins, minerals, omega-3s, they just love taking them even when there's no data. But I do try to point out, look, it is adding to your monthly costs of drugs. It is adding to polypharmacy. It is adding to the potential for drug interaction. So I do actively de-prescribe dietary supplements, including omega-3 fatty acids. Though my success rates are, variable. Not every patient, again, wants to hear the message. Then there are the prescription omega-3 fatty acids, and there are ones, mixtures of EPA, DHA, that are effective at lowering triglycerides. But if you're going to use omega-3 fatty acid to lower triglycerides, I would use Icosapent Ethyl since it has cardiovascular risk reduction data. I wouldn't use the other ones. The only advantage they have is some of them are generic and cheaper, but other than the cost issue, there's really no advantage, and they don't provide cardiovascular risk reduction. Now, if one looks at the trials of mixtures of EPA and DHA and goes back in time, some of the trials do have positive signals. So it's not just that every trial is completely negative. The Ascend trial, for example, which used a mixture of EPA and DHA at low dose, there the trial overall was neutral. But if one looks at the isolated endpoint, and some people say this isn't statistically appropriate, but one looks at the isolated endpoint of vascular death, there was a nominally statistically significant reduction in that endpoint. If one looks at the VITAL trial, again, the correct way to interpret the overall trial was neutral, not showing benefit. But there, again, low dose mixture EPA, DHA, some of the post hoc analyses, individual endpoints and subgroups of things like MI, were significantly lower. I mean, it did look like there might be something going on there. But again, that level of data isn't enough to actually recommend to a patient, hey, do this because there are some signals. That's very different than the story for pure EPA in the form of Icosapent Ethyl, which is an ethyl ester of EPA. There we have the Reduce-It trial that I reviewed, but for the sake of time, I didn't review, though mention the Jealous trial. So a separate independent trial that was done of Icosapent Ethyl at a bit of a lower dose than we use, 1.8 grams a day, versus control. There was no actual placebo, but it was a randomized open label trial with blinded assessment of endpoints. So, it was rigorous, but not as rigorous as Reduce. But that trial showed a 19% relative risk reduction in events with a lower dose of Icosapent Ethyl in Japanese patients who have, at least at that time, who had higher baseline levels of EPA than Western populations. So they had less of a delta in their EPA levels. They started off higher and they went high, but in Reduce It, we started off really low and went to that same or similar level as Jealous. So to me, the fact that there's a 19% relative risk reduction in Jealous, a 25% reduction in first events, 32% reduction in total events, and Reduce It I mean, it makes perfect sense with that compound. And it's an error I think physicians sometimes make, expecting everything to be a class effect. It's just not the case. I mean, it is the case sometimes. For SGLT2 inhibitors, those drugs all seem to reduce heart failure and improve kidney outcomes. That seems to be a class effect in addition to glucose lowering. But what about the GLP-1 receptor agonists? They all lower glucose. They're great glucose lowering drugs for patients with diabetes, but some of them have reduced MACE, major adverse cardiovascular events, very significantly. Others have not and have been neutral. So it wouldn't be fair to say, oh, all these GLP-1 agonists, they're reducing glucose and therefore they must all reduce cardiovascular events, and to extrapolate to the drugs that didn't reduce cardiovascular events, assuming that somehow they might because other trials in that class were positive. That would be incorrect. But likewise, it would be incorrect to say, oh, I don't believe the positive trials because of the negative trials with GLP-1 receptor agonists. So it's the same thing here. The EPA DHA formulations haven't as clearly worked. Now, the one studied in Strength, that was a prescription drug, 4 grams a day of a mixture of EPA DHA that was a carboxylic acid. And the company wisely withdrew that drug after the Strength trial was, once they saw the results and knew it was negative, that the Data Safety Monitoring Board terminated that trial for futility, appropriately so. But, that was a well-done trial, but of a different drug, of an EPA DHA mixture and a carboxylic acid. So did the trial fail because it's a carboxylic acid in Reduce It and in Gellus we had used and they had used an ethyl ester? Maybe. Is it that we used pure EPA and Reduce It and they had in Gellus and Strength was a mixture of EPA and DHA? Maybe that contributed to as well, because as I mentioned, there's some data showing not that DHA is bad, but it's countering at least some of the biological effects of EPA. And that's, some work that I cited, the membrane, cell membrane work that Preston Mason's done, which, by the way, an independent separate lab has essentially found the same thing, a lab at Northwestern University in Chicago. So, multiple lines of basic science evidence, imaging trial evidence, and clinical trial evidence show that EPA actually works for cardiovascular risk reduction, whereas the story for EPA and DHA is much more mixed. And I think, there probably has to do with the population study, the exact formulation studied, the carboxylic acid preparation used in Strength, definitely a bad one. But, some of the other EPA DHA preparations used in the past, like in the GISI Prevenzione trial, where there was a modest benefit, again, I'm not discounting those, but none of that is robust enough benefit in the contemporary era that I think it's actionable. So where does that lead us to? Even though many times, doctors, when they're giving a talk like this, I like to say this is a class effect. It's not appropriate to say that here. This is really an icosapent ethyl effect.
Thank you. I think you touched upon a couple of other questions. One was that, would you comment on the use of fish oils and dietary supplements? I think we've got our response there. And then on those similar lines, you just touched about the basic science, the biochemistry. I'm sure a lot of interesting work is going on. Would you want to comment a little bit further on those biochemistry, the biochemical mechanisms that are being discovered?
Absolutely. I mean, we could easily, do an hour or two talking about that. I mentioned the work on cell membrane preparations that Dr. Mason's lab has done, in many cases, along with his very talented PhD student, Sam Shart. And, they've shown that EPA stabilizes cell membranes. Again, these are cell membrane preparations, an experimental model, whereas DHA disrupts cell membranes. And maybe that cell membrane stabilization capability of EPA is why we saw less sudden cardiac death. Maybe it's a reduction in malignant ventricular arrhythmias. We didn't actually measure arrhythmias or reduce it. I'm speculating, but we did reduce sudden cardiac death and cardiac arrest. There, I'm not speculating. That was blinded, independently adjudicated endpoints. So that cell membrane stabilization could explain a lot. The countering effects of DHA could explain why the EPA DHA story has been so mixed or outright negative in trials like OMEME and Strength. Other benefits that have been seen are, from imaging studies, I don't know if you would say this is basic science, regression of coronary plaque, in particular, sort of vulnerable plaque regressing. Other sorts of truly basic science mechanisms are decreases in oxidation of LDL cholesterol. That's the one potentially overlapping mechanism between intense LDL reduction and EPA. But other than that, all the other benefits of EPA really are independent, I think, of LDL reduction and include things like antioxidant effects, also include things like anti-inflammatory effects, but not in the way that many people think sort of simplistically of, oh, CRP, IL-6. I mean, there might be some modest effects, but really what I'm talking about is much more fundamental anti-inflammatory effects induced by EPA and very high levels of EPA, because EPA forms many important downstream potent anti-inflammatory mediators, things like SPMs or specialized pro-resolving mediators that likely account for a lot of its benefit, but to date haven't been that well studied, certainly in the context of clinical trials. So I think there's a lot more to come in the next decade in omega-3 fatty acid biology. We're still learning a lot about the specific enzymatic interconversion pathways. There's people studying other omega-3 fatty acids like DPA. So, I think we're going to learn a lot more about cardiovascular benefits and potentially benefits in other sorts of organ systems of omega-3 fatty acids. But what we have right now is a very large evidence base from clinical trials, imaging trials, all buttressed by basic science, supporting the health values, the medicinal values of EPA.
Well, thank you, Professor Bhatt. I think we're nearly at the hour, so I'm going to wrap up now with a vote of thanks. Thank you so much from the entire Wiley Knowledge Hub team for this very insightful presentation and for answering some of the audience questions. I hope it's been very beneficial to our audience too. We look forward to meeting everyone again when we bring our next webinar on April 7th on the role of Lp(a) in CVD risk. And our speaker then will be Dr. Samer Elaham from the Heart and Vascular Institute, Cleveland Clinic, Abu Dhabi. Once again, I want to thank everyone for the participation, and Professor Bhatt, especially thank you for this wonderful talk. The recordings of this webcast will be available shortly on the Wiley ASCVD and the Lipidology Knowledge Hub to view these and other relevant resources. Thank you very much.
Thank you.